Good afternoon, everyone, and welcome to today's webinar hosted by Region 10 chapters of HFMA. The topic for today's webinar is Attacking Managed Care Denials, the New Battleground. This is part 2 of a two-part series. I am happy to welcome today's guest presenters. We have three: Day Skeetha, Stephanie Worth, and Janet Petty. Day Iskeetha brings over 30 years experience in healthcare reimbursement, hospital business operations, contracting, and compliance implementation. Additionally, her experience includes 8 years as a director of physician medical management billing service, which included completing an integrated business office between a hospital and a large physician clinic. She has been an entrepreneur in hospital and physician practice accounts, receivable management, and a leader in redesigning numerous organizations. Stephanie Worth is Revenue Cycle Director for Spanish Peaks Regional Health Center. She has experience in all aspects of the revenue cycle. Stephanie is also a past president of the Colorado HFMA chapter. I'm also pleased to welcome Janet Petty, who is a Revenue Cycle Director at St. Vincent General Hospital District, Aca in Colorado. She has 30 years experience working in the hospital revenue cycle. For the past year, she's been the chair of the Western Healthcare Alliance Peer Group and is working on her master's degree in business. So with that, I will hand the call over to today's presenters. Day, I believe you are up first.
Great. It's great to be back with my Region 10 family. I live in Idaho, so it's kind of a treat when I get to teach and work with great hospitals from Region 10. We're going to continue today with what we started yesterday, so hopefully you've been able to be with us both days. Today we're going to talk again about some of the examples of especially Medicare Advantage English. It is the new market that we're going to have to become much more familiar with, the rules, how they work, and then of course just some regular managed care or commercial English as well. So on slide 2, I just want to introduce you again to the reason that a lot of this has become on my radar screen. This is actually my 40th year. We need to update that bio. It's okay. I don't mind being 10 years younger, but probably after 40 years of doing this, I would love to tell you I'm bored. I mean, I'm looking at Stephanie, looking at Janet, 30 years. I mean, we've been doing this a long time. And unfortunately, some of the things we battle today, payment for appropriate services, denials for unrealistic reasons, battles to get appeals, those battles I did 40 years ago. And 20 years in my Idaho hospital and 20 years since then working with hospitals on a variety of documentation and challenges and payment issues, that hasn't changed. And I think if we did a better job of letting our public know that we have like 500 payers in this country, 500 different sets of rules, the complexity of healthcare is not really understood. I mean, until you try to access healthcare, you don't know how complex it is. But most of our public, thank goodness, don't have to access hospitals, don't have to. So this is when I became aware, and I do this free webinar from Compliance 360. In fact, we're doing one tomorrow on kind of an expanded version of what I've been doing here. And I asked the question, who else is causing us anguish besides the RACs? And 4 years ago, I started seeing this massive growth in Medicare Advantage and commercial denials. You know, they always were kind of a pain, but we always blamed it on the RAC and Medicare traditional. Not so. The real anguish that's costing us labor cost and lost dollars is in the commercial and especially Medicare Advantage. So as you probably know, we have this year's boot camp that we're having, our 4th Net Physician Advisor and Utilization Management Boot Camp, is all about Medicare Advantage because we are not prepared as an industry to deal with this new market. So on slide 3, let's talk about some of the things that I'm hearing from other, and I mean, I could write volumes on it, but I threw a few of these in because I think we learn from other people's unfortunate situations. One carrier has it listed HDI. Now remember, the insurance carriers hire these external companies to audit you. So make sure you always ask, who is this? What company are you? Are you Medicare Advantage? Are you commercial? So in this example, HDI, they asked for 10 cases. They were all Medicare Advantage. The dates of service were from 2016 to 18. One case had a 1-day length of stay, and they all say the same thing. The patient could have been safely and appropriate care in outpatient level care. By the way, you never accept that without justification. What criteria were they using to determine. And remember what yesterday was, that we learned that if a medical necessity denial, which is what they're using, they're not saying those words, they're just saying a lower level of care, which is observation usually. So the kicker for this example from Western Connecticut was, I have already been denied 4 of these cases in 16 and 17, 4 of the 10, and 1 was overturned on peer-to-peer phone call. The other 3 were overturned on written appeal. How can they possibly do this again? Well, they can't. But you have to be careful to remember that it costs, you get to say, first of all, get your attorney letter ready again and take that paragraph, remember from the medical necessity chapter of the Managed Medicare Manual that says once you have had an approval, a prior approval, they cannot come back later and deny for medical necessity. Use it, remind these, and send this to HDI, but definitely send it to the payer. Notify CMS, file a formal complaint again. You've been shown how to do it, because this is the sort of stuff that most hospitals are like, well, I guess we got to downgrade it to OBS. Well, I guess we better get back the money. We have got to stop, because they're wrong and it's abusive. But also, it costs you labor time. Keep track of these. We talked yesterday, our contracting folks need to hear from us. We need to decide, is this worth having a contract? What is the cost of administrating this contract? Many of your contract management folks have no idea that you're going through all this. So track and trend the cost to fight these that are inappropriate. But always remember, even at the initial appeal, you need to say, show me the criteria that it didn't pass. Now that's a secondary issue. This one, they had no right to do it to begin with. Then on slide 4, this was an interesting one. This came from an Illinois 80-bed hospital. She said, for the past month or so, we've been getting letters from United Healthcare, my favorite, wanting the medical records on all our outpatient services. Listen to this, outpatient services. And even when they were secondary payer and they owed us less than $100, they wanted the records. They're asking for records for simple CBCs, strep tests, drug screening, mammograms, colonoscopies. In many cases, it cost us more to send them those records than our actual reimbursement would be. I filed a complaint with our United Healthcare advocate, and we have a phone call set up. They're calling it prepayment letters. In many cases, we have a prior auth, and they're still wanting these records. Now other payers are starting to do the same thing. Where one goeth, others followeth. Number 1, what does your contract say about requesting of records, and what is the rationale for these? Prepayment letters, since when? Why are these allowed? What are you doing? Get your attorneys involved. Stop the crazies. This is massively expensive, and the question is, United, if you're Medicare Advantage, we're filing a complaint with CMS. If this is Medicare Commercial, we're going to look at our contract and we're going to tell them, we're going to go to the employers who they have contracts with and share the cost of health care. You're massively increasing the cost of health care by asking for records for $2.10. There's no rationale for all these outpatient CBCs. What do you need it for? Are they trying to gather up diagnoses again to try to increase their payment? Maybe they missed it on this patient only had outpatient. Drug screening, what's those diagnoses? Do you think maybe? I mean, I'm getting to be a little cynical because there's so much of this happening and the hospitals are just left in a fight that costs you major amounts of money. Let's talk about slide 5. Now, this is interesting. Again, this is some of the anguish. This may be a real issue for us because CMS is the only one doing it. You'll remember in the Trump administration, they're talking about patients over paperwork, remember? And we just love that, except CMS is not our only payer. And unless we get one payer for the country, we got 500 different sets of rules. And Medicare is one of those sets of rules. They have come back and they've postponed it because the concern was, if you remember the way your physicians have to do leveling 1 through 5, there's medical decision-making, review of systems, family history, all that goes into determining level 1 through 5. Well, in CMS's wisdom, they said, let's have those doctors stop having to chart all that stuff all the time, and we'll just change the way they get paid, and we will start paying a level 1 at one rate, level 2 through 5 at a different rate. So it's one payment for all. And of course, the specialty groups were not going to get paid more than the primary care docs. And they started creating some additional codes for add-on for time or add-on for complexity. And we went, well, that's just a 5, guys. But instead, they decided this would be simpler, patients over paperwork. The problem is, and we had a phone call, remember CMS did an open door on this, and we talked about it and said, is Blue Cross following this? How about Aetna? How about United? No, just us, just CMS traditional. Well, then how do you think you can change the world for CPT guidance on 1 through 5 when it's just you doing it? So there were 3 things, 170 groups commented, they put it on hold because they really liked that they don't have to redocument the history of the patient every visit. They liked they got to remove the requirement to justify home visits rather than an office visit. And they got to revisit the focus on history since the last visit, not the history of the patient, because it was already there. I mean, those are really good enhancements. The question is, did Blue Cross buy off on that? How about even that much of a change? So when we work with physicians and we teach them how to chart their levels, I will tell them that CMS is looking to make a change. I will tell them no other payers bought off on the change. How can a physician possibly change the way they chart? You think they chart Medicare one way and all the other payers a different way? Not going to happen. So this did nothing more than confuse our docs because Medicare is the only one who did it, and I guess they forgot there's a whole bunch of other payers. On slide 6, this is another area of anguish. We have had Cigna. Now remember, other payers follow suit. Cigna has published they will no longer pay drug administration separately, effective May this month. Now it's important that I made a typo in there. It's important that you notice they're no longer paying separately for giving of the drugs and hydration. They're going to pay only for the incident. They consider these incidental to the primary service and not separately. So the question is, what's the primary service? Have you asked them? We've asked Cigna. So essentially they stopped paying for IV antibiotic therapy, injections, infusions, and hydration. The CPT codes that were left were chemos. So they would pay separate for those. Here's the question, what's the primary service? In your outpatient IV clinic, the drug? So they're going to give you full bill charges for drugs? Because how else are you going to cover the 3 hours of a nurse standing there administering it and all this routine supplies that are included? Because we don't charge setup and cleanup and the tubing. What are we actually getting paid? And if you think Cigna's the only one doing this, they're the first one to do it. So now is our chance to say, yo, what's the primary service? And they say things like, well, the doctor got paid. The doctor doesn't have anything to do with this. This is a hospital-based outpatient clinic, IV antibiotic therapy clinic. What about your ER visits? So this is huge in the area of your outpatient drug administration clinics. You got to get on the phone immediately. Cigna's who's doing it. I've given you the reference. You really need to find out what's the primary service. We have been told it's the drugs. Full bill charges then, no reduction. Let's have full bill charges. And some IV antibiotic meds are not very expensive, but of course others are, but not chemo. Remember, chemo is excluded. So it's just your IV antibiotic therapies, it's your injections, it's your hydrations and OBS. Okay, it's all those are gone with Cigna as a commercial payer and probably Medicare Advantage as well. Slide 7, everybody really, really hates prior authorizations. Yep, here's another one that's really important to watch. The American Medical Association did a survey of, I think it was 1,100 physicians, and asked about the high cost of prior auth. How would you describe the burden? 84% rated it very high. They said it has gotten much worse over the last 5 years. They also said that it's costing them about 14 hours a week to try to get prescriptions and services approved. 2 business days are wasted of hours. Now, you know what they didn't ask? They didn't ask the hospitals. What about us trying to get inpatient versus OBS? What about us trying to get chemotherapy drugs covered? You know, that if it's a hospital-based, we're the ones doing. They only ask the docs. When you add in the hospital cost of trying to get all the prior auths, it's astronomically expensive. So CMS wants to eliminate faxes by next year and we can all go digital. I think that's groovy. How does that change the cost of the labor? Because that's just the cost of sending a fax. So the real cost is the 8 to 14 hours in a doctor's office and probably at least that much in a hospital trying to get these payers to authorize care. Lots of conversation about prior auth, but they believe that we'll just give the hospital, let the payers see the records and they can just do it. Be very careful when you start letting anybody in your records. Patients may have their own opinion about that. So this is Medicare doing the talking right now. They are not really where the big hit is. Medicare traditional, how many of you do prior auths with them? Nobody. Medicare Advantage, lots of prior auths. So people are discussing this. Get in the conversation. Share your real data, not your horror stories. Let's talk about readmissions, page 8. This is when I work with URs, this is when I get a little confused because I ask the question, what's Medicare tradition? Use your words correctly. What is traditional Medicare's rule about readmissions? And they'll say 30-day, it's 30-day. If 2 readmissions happen in the same 30-day period at the same hospital for related symptoms and diagnoses, they got to be collapsed. That's the wrong answer. You're being brainwashed by the Medicare Advantage plans. Medicare traditional is the same patient, the same day, the same diagnosis or symptoms in the same hospital must be collapsed. Same day, traditional Medicare. Well, what's the 30-day thing then? Well, look at page 9. There is a 30-day readmission where CMS is tracking certain medical diagnoses especially, and they're looking at patterns that you have. So if I have COPD, it's one that's getting tracked, and I have a readmission and my readmission patterns for COPD at your hospital, if that 30-day pattern is above the national standard, you're going to be penalized in next year's payments for all your DRGs. So this is a patterns, and it's done a year at a time. So when you read the data that says hospitals had a 0.20 or 0.02 reduction in their inpatient payments from Medicare because of their 30-day readmission patterns, that's how traditional works. But every day of the week, you're billing these. So I come in on today, and I come back 10 days later, COPD, you bill 2, you get paid 2. It is not a 30-day readmission for traditional, it's day of. So again, why do we need to get our Medicare Advantage A game on? We talk about all of this in the boot camp. We have to, because we've got to get our people trained appropriately. Well, then what about those stinking Medicare Advantage plans? Ha ha, slide 10. They do this in commercial too, but we see it more in Medicare Advantage. United, again, my friend and yours, we really have issues with what they, in the policy and versus the contract. Now, this is what you want to get good at. In the contract, it clearly states that, they will do medically necessary admits. But out on their policies, it says things like, if they are related, we will not let you have 2 separate admissions in a 30-day period. Please tell me the definition of related. And United goes as far as says preventable. The second admission in a 30-day period, you don't get paid because it was preventable. Well, you want to define that? But the one that everybody's using is related. And here's my heads up. Chronic conditions will always be, I will always have diabetes. Always, always. So when and remember, these are computers talking to computers. So think about the UB04. Across the bottom are all the new ICD-10 codes, right? Where will diabetes fall? Is it the second, the third, the fourth? So if I come in one day and I have pneumonia and I come back 18 days later, I will still have diabetes. So are they related because I got readmitted for a broken leg? Are they related because I got readmitted because my pneumonia popped back up again because I'm compromised because of my diabetes? How can you give those up as readmissions related? You better get the definition, because hospitals, we know we have chronic conditions that will always be on that UB04. So is it the primary diagnosis? Maybe that's what you're fighting for. The primary diagnosis, first position. If that's the same, they're related. Maybe that's your give. But anywhere else, it's not related, and we deserve the second payment. So these are very big issues that leads me again to slide 11. I shared this with you yesterday. Medicare finally, a couple years ago, maybe 2, gave hospitals and docs the ability to file complaints against Medicare Advantage plans for abuse. Now remember the rules. You must contact your MA plan first to try to resolve it. So some of the stuff I'm telling you that you saw examples of, you got to contact them first. So, and then if they don't, you file a formal complaint with CMS. Now, CMS has given us, remember, Papa Bear Traditional oversees all Medicare Advantage plans. So this is important because you need to know how to file your complaints. So if I want to tell you a success story, I told this yesterday, and I don't know if you all had a chance to hear it. This is one of the greatest success stories. This is a little 80-bed hospital who's been nailed between Aetna and United. They're contracted with Aetna. They are not with United. And I helped her through this one, and she's going to speak at our boot camp again this year. There's a little compliance officer. She's doing all this. She's fighting it out with every payer to try to save their inpatients. And they've been denied, like readmissions were related because the guy was smoking the first time they offered him smoking cessation. He refused. Aetna denied the second one for related, and then they hit him with preventable. And I went, you've got to be kidding. Do we go in to take people's cigarettes from them now? How do you prevent that? So they believe they had some abuse going on. So they had 2 mental health cases in these 2 examples that she told me about. They filed a complaint. They reached out to Aetna first, never heard from them, filed a complaint. They were over a year old. Aetna replies rapidly. Again, filed the complaint with CMS, not Aetna, it's Medicare, their boss. Then the next one was United Healthcare. She said, that was another matter. She said, they just stopped taking my phone calls. They just stopped talking. They wouldn't pay. They wouldn't do anything. So she sent them a note, said, I'm going to file another complaint against you. She did in March. 15 days later, after the second complaint, both accounts were paid. Not only were they paid, but because she's not contracting, traditional Medicare kicks in, and they had to pay her interest. And it even gets better. Medicare Part C, the advocate that you filed the complaint with, told them they had to send her a letter explaining why they didn't do this and why it took so long. Now, here's my concern. The big thing we talk about and what we'll be learning more about in our boot camp, and again, remember, we're the only ones that offer CAW reduced rates, remember, and you can do live web streaming if you can't afford to get to DC. We'd love to see you, but we can see you either way. And of course, we're getting the big discount right now, ends the 31st, early bird. So the only reason I'm telling you, because we're going to go through a bunch of this, and you're going to learn from the people who live it right now. And so when you file a complaint, you've got to give them really good examples. Make sure they're valid and they're good examples. You need to understand when you're not contracted with a Medicare Advantage plan, they cannot force their rules on you because you have nothing other than traditional Medicare you have to follow. Now, I need to wrap up to give our other speakers some time here. So some proactive ideas on contracting on slide 13. I mean, I've kind of talked them through a lot because we don't have a lot of time today. These are just some really good things that we talk about all the time, how to build better contracts with your MA plans. Define an inpatient. Define it. What clip they use, medically necessary guidelines. That means nothing. What are they using? Interqual? MCG? What are they using? Of course, Medicare traditional uses neither. So the question is, what are they using? And when you put out a request for peer-to-peer phone call, how many hours do they have to reply back? I mean, these are really important that you get good at this. And then, of course, the definition of related. Gosh, you got to protect yourself. So the last thing on slide 14, these are the things that make us all nervous. If you haven't been following this, there's a free class out on my website that's called What Does Disruption Look Like? And we really talk about the rural communities and how we're in trouble, and 450 hospitals, according to Morgan Stanley, are at risk of closing. And those of us in Idaho, I can tell you that the Idaho Hospital Association, when they were doing great education on helping us understand if we should vote for the Medicaid expansion, which the public did vote 65% to do it in Idaho, they showed that of our 27 rural critical access small hospitals, only 8 were financially viable. Now start whacking them to death with this, what's going on with all these payers. So you can have your own opinion about some of the things going on in the nation about single payer, Medicare for all, or whatever. We got to cut down the complexities of managing all these Medicare, all these plans, and nobody knows how hard it is on us because we're really probably not doing a really good job. So you've got your legislators you can talk to. And then last but not least, I kept trying to figure out, how are we getting all these Medicare Advantage plans? Where are they coming from? All these patients in the middle of nowhere. We got all these Medicare Advantage plans. I mean, really? And Stephanie will tell you a little bit about the law, about whether they can sell in your community. But here's what we also discovered. This is an article from, I believe this is New York, Washington Post. And this was a patient in New York who turned 65. She signed up for traditional Medicare, went to her doctor, went to her hospital that she'd always gone to, right? She received a bill that told her she was out of network and she was not supposed to go to that hospital or that doctor. And she said, what are you talking about? I have traditional Medicare. Well, what happens for all of you turning 65, and when you do your community boot camps and teach them Medicare 101, get out on my website, take that class, go out and do it. The thing I discovered, and we discovered from this article, was that if you work for an employer, let's use Boeing, let's use the Forest Service, let's use the school districts, anybody who has like a Blue Cross plan that's commercial, if the Blue Cross plan also offers a Medicare Advantage, they will be automatically moved to the Medicare Advantage plan unless they opt out. Go read this article. It's enough to make your heart ache. What? So when you're turning 65, any of you that have done that, you know you get a ton of paperwork. Every Medicare supplement sending you, sign up for me. In the midst of all that, you probably got a letter from your Human Resource Department at the Forest Service that said, hey, we have Blue Cross. We are making a transparent, it's going to be seamless, is what Medicare calls it, seamless to move you from Blue Cross Commercial to Blue Cross Medicare Advantage. And you don't have to do a single thing. It'll just happen. And you have to realize that Medicare on slide 16 was absolutely flabbergasted that the industry went nuts after the public went nuts after that article came out. And so CMS temporarily stopped. We have no idea if they started up again, allowing new insurances to sign up to the seamless automatic enrollment. Don't tell me insurance companies don't have massive power here. By the way, they call themselves the health insurance plans. So CMS disclosed there were 29 Medicare Advantage companies already doing automatic referral ins. So, but no new ones can be added. Well, did you see who the old ones were? The Blues, United, Aetna, Blue Shield, keep going. So this is probably, again, a good thing for our hospitals, heads up our docs. If somebody's turning 65, the first thing you should be saying is, does your employer currently have like a Blues plan, a Humana plan, an Aetna plan, a Cigna plan that also offers Medicare Advantage? They will be automatically enrolled. So be sure they go in and talk to Human Resources to tell them what they want so they understand this. Because again, Medicare, when they retire, is going to be automatically set up to move them to a Medicare Advantage. And then, of course, on slide 17, I'm going to turn this over to Stephanie here in a minute. She's going to be telling us what's been going on with her. She's got a couple great stories. And then over to Janet, who will also be telling us a couple great examples for them. But if any of you want to sign up for the free info line that I do, remember you can send me your email. And tomorrow it's going to go out with a whole bunch more updates that I've been sharing with you. And then, of course, if you want more information about how to get involved with our boot camp in July, please get on there and take a look at that, and then let me know if you have any questions. All right, Nikki, why don't you turn us over to Stephanie and let her tell us about her situation at Spanish Fork.
Well, good afternoon. Huerfano County Hospital District is comprised of a 120-bed VA nursing home. We also have a 20-bed critical access hospital, and we have 4 clinics, one of which is an RHC, and we also have a grant-funded women's clinic. So kind of a complex little health system out here in southern Colorado. To begin with, we have a nursing home, the Spanish Peaks Veterans Community Living Center. It has 120 beds, and because it is VA, we are required to keep a predominantly VA patient population or resident population. We are allowed to bill Medicaid, and we are allowed to bill some self-pay as long as we keep that ratio. And what we noticed is we had residents arriving from out of state, definitely out of our area, and they were bringing Medicare Advantage plans with them from their previous communities. And it really kind of caught us by surprise. It was a phenomenon that we had not experienced before, and so before we knew it, we had 3 patients, residents, one of whom immediately needed a lot of hospital care. And we found out that we were not going to be paid. And it immediately caused us to change our admission process. We had to implement a process for getting the family, because many of these patients have POAs, to get the process started to get the patient off of the Medicare Advantage plan and back onto traditional Medicare. And it was very difficult for some of these families. The plans will not talk to us. They will only talk to the patient or the families. And in one case, we had a patient go on and off of the plan twice in the period of about 6 months. We never have fully been able to get to the bottom of how that happened because the plan won't talk to us. I did initiate a complaint on that, and I'm still waiting to hear what happened because we don't want that to happen again. In addition to having just the routine outpatient services, lab work, diagnostic, we had some inpatients, and we had refusals saying they would not allow us to admit the patient. And it was only when we stated that we would transfer them to a PPS hospital that was contracted, the closest one being an hour away by ambulance, that they went ahead and approved it. But in many cases, they were still waiting to be paid on some of those claims. And with the outpatient claims, they were very unsympathetic to the patients. They just said they know they have a Medicare Advantage plan that is only good in their community, and they refused to pay us and told us to bill the patient. So very unfortunate for all of us. Second, if you want to go to the next slide, we are a popular tourist and second homeowner destination, and we have a lot of people who stay here for long periods of time. They'll be here for the whole summer, half of the year, and many of them need routine health care for chronic conditions that are being managed at home with their PCPs. And we started experiencing denials, again, unsympathetic, bill the patient. We also have a local insurance broker offering Humana Gold. And we were not aware of this until a lot of our local population started showing up with these cards. And we didn't realize that this was happening. So we had to start reacting. In addition to that, we had a complaint by a patient. She called our clinic and said that she had been contacted by a doctor. She didn't know who this person was, and she was concerned that it was fraud because her PCP is at one of our clinics. And so I had to do some investigating, and what I found out was this was a doctor hired by Humana to contact all new beneficiaries to do an assessment on them, and then they keep that data. And she just wasn't aware. If she was told, she did not remember, and it frightened her, quite frankly. So one of the things we did right away to react was train our admission staff in both the hospital and the clinics. We had to teach them how to read the eligibility screens in the software to find where it was buried in there that they had a Medicare Advantage plan. And we use Meditech, Change Healthcare in our hospital, and ECW Trizetto in our clinics. So quite a lot of training for a lot of people to get them up to speed on that, and then train them on how to advise our patients that if they're coming for elective services, they do have to be authorized, and in some cases, they can't get authorized at all because they're not allowed to have anything outside of their communities. We have been impacted by this. It's added a lot of complexity. We did end up contracting with Humana because of the numbers of people who had made the switch, thinking that that would help us. But really, we're still experiencing the complexity of getting the authorizations, and then just residually from all the other plans, Kaiser, United. We've got denials. We're still trying to get some of them paid, and then the patient complaints regarding balance billing. So we are still trying to work through and refine our processes to respond. And I'm so pleased that Day is leading the charge on this, because it is something that is going to continue to grow, and we're happy to get on top of it.
Thanks, Stephanie. That was excellent. Excellent. Okay, it's your turn, Janet. Take us to slide 5.
Thank you so much, everybody. And go ahead and take us to slide 23. I just wanted to...
Sorry.
Can you hear me okay?
No, you got Dr. There. That's better.
Okay. So thank you to Stephanie, because her story is a lot like us up at St. Vincent. We are an 8-bed critical access hospital, and we also have an ambulance service. We are within an hour of Vail, Breckenridge, Copper Mountain. So we have a lot of residents that have second homes in Leadville, but we also have a lot of people who come in to the ski resorts and come to our city. So we see a lot of the perfect example is we had a patient come in that has a community advantage plan out of Oklahoma. We also have an ambulance service. So our ambulance went out and got her, came to our hospital. She was having a stroke, so we took her over to Denver, and the Advantage plan is not paying for our ambulance service. And then once we were trying to bring her back to our swing beds for rehab after her stay in Denver, and she has no out-of-network benefits at all for any services, lab, radiology, physical therapy, unless she goes back to her home community in Oklahoma. And the sad part about that is, so she was home for about 2 weeks, fell, broke her ankle, was back another ride in the ambulance, was back in our ER, and ended up staying about 4 days. So I was able to get an authorization for the inpatient stay because it started as an emergency, and then was able to get a 5-day swing bed stay authorization number. But the only way that you're going to get paid from any of these Advantage plans that have their own community doctors and where the patients have to stay in their own community is with authorizations. And of course, on the outpatient side, most of them have zero benefits. Slide 24, please. Then we also, since Leadville is at 10,200 feet, there's also issues with oxygen and high altitude sickness. So, we fight every day with, upset patients that they have no benefits in our outpatient services or DME. There are a growing number of Medicare patients who have opted into these Medicare Advantage plans, and we really have to make sure we do lots of training with our admissions team so we can board off those denials in the front side. We also, here in Colorado, have a Medicare Advantage plan, Rocky Mountain Health Plan, that requires the hospital side to be billed to traditional Medicare, and then the physician side to be billed to Rocky Mountain Health Plans. So for those of us that have computer systems that try to automate the, where the insurances go electronically, that's been a real hindrance to our accounts receivable. Next slide.
That one was amazing for me. Okay.
All right. Well,
let me share two things from those two great speakers, and then we'll turn it over to Q&A. First of all, I'm so thrilled to hear you start talking like a well-trained MA person. They're using words like community benefits. I didn't know that a year ago. I have, like I told you yesterday, I have attended a Better Medicare Alliance conference, and I was the only person in the room that was a provider rep, raising my hand most of the time going, what does that mean? What does that mean? What does that mean? Then I understood much more than I did a year and a half ago. But I then had a real life experience, just like these two great hospitals and what they've lived through. I had a family member go out of community for an emergency care. Oh, her MA plan covered it, but no follow-up. So when she came back, she could have cover, but the hospital she was at had to be air flighted to said, we need you to see our doctors down here for follow-up. And what did her MA plan say? That'll be all out of pocket, you're out of network. And to opt out of Medicare, there's only a matter of months that they can do that. Like November, and they've expanded till the end of March now. So right now, if Stephanie or Janet run up, like they're telling you, they run up against these patients who just came in to see their child or their second residence, and they have to have ongoing antibiotic or ongoing physical therapy. That's a killer. The physical therapy, they could have had an ER visit covered, inpatient covered. Now they need rehab, and the rehab will be out of network, usually no benefit, and your patient gets to pay you for that. And it's May. They can't opt back into Medicare now. It's too late. They're stuck for the rest of the year. So our ability to help our patients opt out, you got to study those dates. You got to study when they can. Watch TV, figure out when it is, because they all advertise constantly on TV. But I believe it's the middle of November to the middle of the 1st of November to the middle of December-ish. That's general enrollment. And then they can opt out through the end of March now. And that's a change that didn't used to be there. So having said that, this stuff is so amazing to learn, and I so appreciate you two willingness to share your stories. All right, Nikki, now open it up for Q&A.
All right. Thank you so much, Dave, Stephanie, and Janet. Just a great collaboration offering those different perspectives. Before I take our first question, just reminding everyone to type your questions into that chat panel located to the right of your screen, and we'll take as many as time will allow. I'll go ahead and address 2 questions. The replay will be available within the next 24 hours, and we'll make sure to provide you guys with access to that. And in your handouts panel, in the middle of the presentation, I uploaded another PDF. So you now have access to part 1 and part 2. So you don't have to wait for those. You can get that now. All right. So our first question, it reads, how is Medicare bad debt being addressed in MA plan contracts?
I will ask our 2 guest speakers if they have experience with that. Stephanie or Janet?
Well, this is Stephanie. My understanding is that you can claim it if it's in your contract, but that is something that I need to explore with our cost report auditor, and I intend to be doing that.
How about you, Janet?
That's the same with me.
Okay, so here's my thought too. Medicare Advantage, unless you have something in there how would you even get any consideration for bad debt? So you're having to tell traditional Medicare cost report people, great people that. We have Medicare Advantage bad debt. Can we declare it on traditional Medicare cost report? That's the question. Can we get any credit for this for MAs on traditional? Now, the big hospitals, cost reports are pretty non-existent to them. So for them, it's probably too bad, so sad, bad debt, you get to eat it. Because traditional Medicare and Medicare Advantage, essentially your patient signed off for traditional to get Medicare Advantage. So you could see somebody might say back to you, well, why would you get the benefit of traditional with bad debt? Patient didn't have traditional, they had MA. So this is a big dollar for dollar for you. You got to, really fight this one thoroughly. The bigger hospitals, there's really nothing for you. It is essentially bad debt, done deal, commercial payer, i.e. MA. Next question, Nikki.
Thank you. The next one reads, when the patient complains about balanced billing, does the health care center provide an avenue for financial assistance to qualify for MCD, CICP, or internal charity?
Okay, you two.
This is Stephanie. Absolutely, we do. And I don't know why, but some of our Medicare Advantage plan patients actually have Medicaid as a secondary. And for those that don't, we definitely get them in with our financial counselor to try and help them with those balances, which is unfortunate again for us, because if they had traditional Medicare, we would have gotten paid at least our Medicare rates, and then we would have just been assisting them with copays and deductibles. But in some cases, we're helping them with the entire bill.
How about you, Janet?
We also do the same. We have a sliding fee schedule that patients can apply for, and it goes on their income. And of course, just like with Stephanie, a lot of our patients qualify for Medicaid because Colorado is an expansion state. So again, we're helping these patients with the full balances, a $3,000 ambulance ride and, several months of physical therapy, and the patients are still left with several $100s even after our charity programs.
Okay, let me help you with this one too. This is such good information. Thank you for this. The Medicare traditional, the patients can have a Medicare supplement. So 86 or 83% of our patients have one. So Stephanie and Janet would not be left collecting anything from the patient if they had a supplement and Medicare traditional. Medicare Advantage does not allow a supplement. So your Medicare Advantage patient will always be owing out of pocket unless their plan has waived it. So they would, and that's at $6,700 max that they would have to pay out of pocket. So if they go to be an inpatient, they will owe the $1,600 inpatient. They will not have a Medicare supplement to help them with that. Now, so that's kind of an important piece with all this new business. You may have more out-of-pocket collections on Medicare Advantage than you ever had with traditional because of the supplement. That's a big piece. The second thing is the Medicare, Medicare, Medicaid is a new area where the Medicare Advantage plans talk openly about capturing that new business. Because guess what? They get paid per member per month to manage their health, and they've got Medicaid as a secondary payer. What a bonanza. So realize that's it. They have gone after the Medi patient. So you should be seeing more of them. And then the question you need to ask was, well, who pays the inpatient? Okay, United. Who pays the out-of-pocket? Medicaid. So you should have no collection cost out of pocket from the patient on a Medicare Advantage with a Medicaid secondary. Medi. Okay, next question, Nikki.
All right. So in keeping with that comparison, the next question is based on your experience. What are the first-time denial rates for MA plans versus traditional Medicare?
What type of what kind of patient are we talking about? Drugs, inpatient? Does it say?
It does not. Shall we take inpatient?
Yeah. Okay. So the question would be traditional versus MA. What's the overall denial rate from the MA versus traditional?
Right.
Okay. I'll answer that quickly because traditional, without the RAC audits and the 2 midnight rule, you should have had literally no inpatient deductibles for the inpatient denials. You've had the 10 chart audits from the QIO. It's for 1 day and your 0-day stays. Should be minimal, like 10 ever, unless you've got massive error rate, and then you're going to have more. So traditional inpatient should be next to nothing. You're doing it yourself to determine if the 2 midnight rule has been met in the documentation, in the plan. And then traditional is us doing us. MA plans is a commercial payer, United, Humana, Aetna, Cigna, Pacific Source, Select Health. They're making the decision whether the patient met their definition of inpatient. And that's where the denials start. And remember, it's not, they'll give you OBS. So it's not really a denial. I don't call them denials. Remember, I call them downgrades, disputes. So you lost your inpatient, but they'll give you $1.50 for OBS. So it's not truly a denial. It's a disputed status, and you got downgraded to OBS. What percentage? Boy, you know, remember there was a lawsuit filed that said there were 75% more traditional, 75% more MA inpatient disputed statuses than there were with traditional. So the Office of Inspector General is taking a look at that, thinking that the MA plans are being abusive and never giving us an inpatient. It's like, yeah, it's about time. But I don't have data that's hospital specific. I have bigger picture data, but I understand it's not an apples to apples comparison anymore because the inpatient traditional is not getting audited like it did under the RAC. Stephanie and Janet, do you have anything to add to that?
I really don't. I don't have statistics on that.
I don't have specific statistics, but I think when you look at the amount of time and the cost for small facilities, I mean, we're an 8-bed critical access hospital that we have to actually go in and apply for auth, give daily clinicals, and et cetera. It really adds up.
Yeah. Okay, next question then.
I think actually we have exhausted the questions. You guys were just so thorough. You didn't leave a lot of room for them, perhaps. So I'll just tap dance in case some other questions come in the next minute or so. And so I'll be sure to read it aloud. So we are approaching the top of the hour, and I wanted to take a moment to remind everyone that as you exit, you will be prompted with a survey. We would greatly appreciate you sharing your feedback about today's event, the series as a whole, as well as some other topics that you're looking for in future webinars. So Region 10 can craft a schedule that meets the needs of of your particular organization. So no other questions have come in, Day. I know that you are just overflowing with information. So any parting words that you'd like to share with our audience?
Well, I would recommend that they take advantage of all of the free class information we have on our website. So you have that in my email. So anything we're teaching, all the info lines that I do are free as well. Get signed up so you can make sure you get them when they come out, which is about once a month, but they're all on our webpage too. So that webpage is full of free educational material. Just go get it. Hopefully it makes sense. If it doesn't, drop me a note, but take advantage of that. And then, of course, we'd love to have you at our boot camp one way or the other. But the ongoing education that is at no cost, please get it, use it, and you'll see that we also have our Patient Financial Navigator Foundation. That's where all the Medicare 101 classes are. Go get those too. Just make sure that you are a leader of revenue education in your community, not just your hospital.
Perfect. So thank you again to our guest speakers, Dave Skeetha of AR Systems, Stephanie Worth of Spanish Peak Health Center, and Janet Petty of St. Vincent General Hospital. And on behalf of Region 10 chapters of HFMA, we thank you again for taking time out of your day to join us. And we hope to see you online in the near future. Have a great afternoon, everyone.
Thanks, guys. Thanks, Stephanie, Janet. Appreciate you. Bye-bye.